will be lucky enough, I do foresee at someday in the future at PRM to have some sort of quick diagnostic, and we'll know if it's endo or not.
Welcome to Fempower Health. This is Georgie. I'm excited to share with you another episode on dealing with chronic pelvic pain, much of it due to endometriosis. I did a 4-part series earlier this season and it was extremely well received. But you know what? Sometimes there is pelvic pain, and no matter how many surgeries you get, it just won't go away. So I recently saw Dr. Allyson Shrikhande data around the PRM protocol, so I asked her to join us. So she is a dedicated expert in pelvic rehabilitation medicine, as I've already done a couple of episodes on Fempower Health, so it's always a pleasure to have her back. So we're going to uncover how this comprehensive data-driven approach improves function and reduces pain through targeted treatments and lifestyle modifications. So if you want to learn about some of the new strategies for pain management related to endometriosis and other potential causes, please do take a listen, and I hope that this is of help to you. Today, we are here to talk about my audience's favorite topic, which is endometriosis. And it is such a complex condition. I just recently did a 4-part series that was extremely well received. And I saw some of your research on some methodologies that you are doing to help with pelvic pain. And so I want to dive right in and start talking about it. But for those who may not have been introduced to you or listened to our previous episodes together, why don't you just give us the introduction and then we will dive right in.
Sure. So my name is Allyson Shrikhande. I am a physical medicine and rehabilitation doctor, so PM&R. I am co-founder, along with my husband, of Pelvic Rehabilitation Medicine, and we serve patients who have persistent or chronic pelvic pain. And really, as we were founded in May of 2017, originally out of New York City, now 10 states, 14 cities, from New York City to LA, across the country, really have become very much endometriosis focused. And I would say at PRM, or pelvic rehabilitation medicine, we for sure are on the front lines of endo, and on analyzing our data, about 70% of our females either have endometriosis. Some come with a known diagnosis, and others, we help them along their journey.
I also love that you're data driven. I mean, even the very first time we spoke, you were looking at data and also working on healthcare coverage, et cetera. So you always are looking at an innovative way to make sure to help these patients. And so I really appreciate that, and looking forward to diving in. So I guess, because not everyone is going to listen to every single episode. And so maybe we could just do like a 2-minute, the journey of endometriosis and the complexity. And then we can weave in the pain aspects, the surgery, and just all the things that women are suffering through, and how your methodology is helping. So maybe you can talk about like how patients present to you and the struggles that they're having. Maybe we start there.
Yeah, that's a great place to start. Really, again, with endometriosis, it is such a spectrum of a disease, right? Process really depends on the chronicity and the location of where the endometriosis plaques land. So really, they can present from anywhere from just pure bladder issues to pure bowel issues, right? Pain around bowel movements and bloating and constipation, so a lot of GI, or it could be pain around intercourse discomfort during or post, and then sometimes it's more the lower abdominal pain, classically worse with your period, and it can kind of radiate either to the thigh or the buttocks or the lower back. That's the thing with endometriosis. It can be a bit tricky because it presents with multiple different ways. Sometimes all those things, sometimes just one, right? Really, there is for sure a diverse spectrum of how patients come to us with their presentation, and sometimes it's very connected with fertility issues, and sometimes not.
It's interesting what you were saying, because I feel like in the public eye on social media, and even some of the documentaries that have been developed, it's so much about, it comes across as it's like pure pelvic pain. And I guess the way it's been discussed, it's kind of almost an assumption that it's the type of pain and the placement of the pain that you typically feel when you have your menstrual cycle. And here you're talking about all of these different presentations. Do you find that that's like just a common, are you seeing that as like a common perception people have as well?
Yes, and that's part of again the challenge with endometriosis. I mean, as it's one in 9 women, right? So it's extremely prevalent, just as common as asthma or diabetes. I think the issue is the diagnostic, right? There is no non-surgical diagnostic at this point. So quite often the MRI, the imaging can be normal, blood work's normal. And it can be a challenge with the symptoms because that's not every patient we see fits into that classic bucket for endometriosis. And as a young doctor a while back, I learned the hard way because in residency it is a very classic description, but then you realize that it can be more variable. Really, again, it really just depends on the anatomic location of where those little plaques, where they deposit. If they're near the bladder, it's going to be a very bladder forward presentation. So it is important as healthcare providers to raise awareness, educate patients and other healthcare practitioners on this, and then to take a step back and be aware and think of endometriosis in that full spectrum, right? Not such a narrowed view of it, I think, is really important. And again, I learned from just making a mistake with patients and putting them in a bucket and then realizing it was endometriosis.
You've been working on a methodology that can really help with pain. In these episodes that I've done recently, I've been talking to some really interesting experts where, like, for example, I interviewed a surgeon where we spoke about the reason why a lot of the women continue to have pain after they do have laparoscopic surgery, if that is the route, because there's a lot of routes to go, which we can dive into probably throughout this conversation. But should someone have the surgery, it might be because the surgeon didn't look properly in all the deep pockets, because endometriosis is so specialized. And a lot of times people may go to a general OBGYN and they may not know about the hidden pockets, so to speak. And also that when someone is doing the surgery, they really need to take it out like when people have cancer. Like, it's not just take out the endo, it's take out things around it. But when you and I kind of had this prep call, we were talking about, there's still other reasons for that pain. And it's not this, if you have a perfect surgery, you will never have pain again. So can you just talk about that? Because you seem to have a interesting perspective on this.
Sometimes the pain is the bladder pain, right? Sometimes it's bowel movement pain. Sometimes it's intercourse pain, and sometimes it's just pain or discomfort from the belly button to the mid thigh. So it can be anything. And we call them persistent kind of comorbidities that can happen. And we, quite often will say, I'm sure the surgery went very well, but essentially endometriosis has been there for quite some time, right? At least 6 months, but the average is about 7 to 8 years, right? So it's an inflammatory process. So the definition is it's a systemic inflammatory disease process, right? So it's been present in the pelvis for quite some time, many years, quite often, and its presence does a couple things, right, when it's there. The number one thing is it causes your pelvic floor muscles to go into a chronic guarding state where they get short, spastic, and weaker, and they also squeeze those nerves. But that becomes its new normal because over time it just gets guarded, right, and stiff. Number two, what it will do is cause inflammation. We call it neurogenic inflammation around all the different pelvic nerves. There's many peripheral pelvic nerves. And when endometriosis is present, right, there's a release of what we call pro-inflammatory cytokines, or it's a fancy term for that inflammatory soup. So when those pro-inflammatory cytokines are around the pelvic nerves, the pelvic nerves get irritated, and they start to fire when they shouldn't. They fire inappropriately. We call it aberrant firing of the peripheral nociceptors, but really it's just they start to fire like ADHD, right? And then the third thing that happens is something called central sensitization, where there's this wind-up phenomenon of the central nervous system as well when you have endometriosis there for quite some time. So the reason why I say all that is because, well, and there's really changes really in the mRNA of these nerves, right? So we need to reverse those changes. And so even when the endometriosis plaques, which are properly removed by an excellent excision surgeon, well, we need to then fix the nerves and muscles, the peripheral nervous system, central, and the pelvic floor, that they then need to be rehabbed, right? Because you remove that primary pain generator, very important. Remove that inciting event, but then they don't just snap back into place. It does take some rehabilitation. So conceptually, that is what the PRM protocol, that is what we're doing. That's what we're called pelvic rehabilitation medicine, because it's more of a rehab, functional restorative approach to reset, retrain, and reverse the inflammatory process that's been there for so long. So that's conceptually why you could have an excellent surgery, and sometimes things do persist. Yeah, and that is why they need to be reversed and reset and retrained.
There have been some documentaries, and Below the Belt was one of the more recent ones that I'm aware of. And the takeaway I got from there is the criticality. Is that a word? I'm going to make it up as a word now. The critical nature of of getting diagnosed early is really, really important. And it kind of almost wove this story, intentionally or unintentionally, of if you get diagnosed earlier, the likelihood of pain long term is kind of gone. And I'm not sure if it's that simple. So, can you talk about time to diagnosis? Because we know it takes, what, I think an average of 7 to 10 years to get diagnosed, and then these symptoms that you're talking about and the rehab that's required. Have you, in your data, seen any correlations there?
Yeah, that is a very interesting question, and we haven't published on that specifically, but we are starting to now look at the chronicity and timeline and nature of the disease. However, I am on the camp. It is a bit debated, I would say, in the medical world. How to manage it. Is it early diagnosis and then treat with hormones or surgery? I'd say it's still being debated. I am on the camp of early diagnosis as well. I think chronicity is harder for us to manage because, like as I was explaining, if something's there for a long periods of time, it's a concept of neuroplasticity in your body. It's called neuroplasticity. Again, that's what the PRM protocol is doing: reversing, resetting, retraining. And it's just a fancy medical term in rehab, as there are deep changes in your mRNA, right? So, and the longer it's there, the harder it is for us to make people better. So an early diagnosis is excellent because of that, right? For the pain of the central and peripheral nervous system and the pelvic floor too, but mainly the nervous system. And number two, an early diagnosis with a proper excision surgery does help, trying to keep it as contained as possible. It is a chronic systemic, inflammatory disease process, right? So there is no technically cure for it. But when I say as contained as possible, the first surgery I do believe is the most important surgery. Getting an excision surgeon with extra training in endo is really important. And the reason why I say contained as possible is I'll never forget a patient. She flew. I was in New York City, really hadn't started PRM yet, by myself in a private practice, and she flew from LA. And she was 26, and she had been complaining since 16 of symptoms of kind of classic endo. But they, people, the providers were telling her really it's in her head. She was sent to psychiatry because the workup was normal and they weren't, astute on endo. And so, right away, I referred this patient to Dr. Iris Orbach, who at that time was in New York City with me and I worked very closely with. And this poor girl, it was to the point then, though, she needed a colorectal there. She needed a colostomy bag. It had just been a 10-year delay.
Ugh.
So the reason why I'm saying that, because that is why an early diagnosis, right? You want to try to contain this chronic disease as much as you can. And then once I think, there are a lot of lifestyle things that you can do to help really, as much as you can, decrease the inflammatory process, right, in the body, so that we can try to decrease the recurrence rate as much as you can possibly, and work with whatever also hormonal suppression you feel comfortable with. And everyone's different there.
Does excision have to happen? And I'm just going to give this little overview here, but that's the question. I've heard things like, if you don't have pain, don't worry about it, you're fine. By the way, I was asymptomatic and had infertility, and I did get my surgery. So then I hear, well, if you're struggling with infertility, okay, fine. So those are like the two things: if it's pain and if you have infertility. But if you're doing just the hormone suppression just because of the inflammatory process, I guess, where does the decision of excision surgery and the long term impacts on one's body fit in?
Yes, at PRM, we believe in working closely with excision surgeons. So we believe in that in the surgery. However, our mission is to decrease the total number of surgeries our poor patients have to undergo in their lifetime. So I think that there's a balance, right? We see patients, believe it or not, that are having surgeries every 2 to 3 years, or so there's a balance. So that's why it's a tricky question that way. But again, from the data I'm seeing and that we're collecting, because we do have surgeons as well, sprinkled across the country, and collecting our own data on outcomes. I think again, getting an early diagnosis, a proper excision, and then working to decrease the recurrence rate and spread it out as long as you can. So you're not having multiple surgeries when you're young, because every surgery is a trauma or an insult to the body too, right?
Right.
So
So, in your belief, so I guess, where does the hormone therapy fit in? Because I know, like, there are options on, well, you could just take birth control, or you can take NSAIDs if it's not bothering you, and maybe you can delay surgery. So, do you guys have data on that?
A lot of it is the patient's wants and needs
Okay.
first,
Right.
right? We're patient centric, so it's really trying to fulfill a patient's goals. And classically, our core model is a non-operative model, right? That's what our core model at PRM would be, is our procedural office-based procedures. So if patients come in with symptoms of pelvic floor, pelvic pain, right? Anywhere from the belly button to the mid thigh, bowel, bladder, intercourse, we would try to treat them with our procedural approach. And if they do very well, we would leave them, right?
Got it.
It's you're doing great, like you're doing amazing. So I don't know how much of it. The thing is, Georgie, I think we'll be lucky enough. I do foresee at someday in the future at PRM to have some sort of quick diagnostic, and we'll know if it's endo or not.
Right.
So we don't really, we see people post-op, we see people who want surgery tomorrow, and then we see people who are just presenting with some symptoms. And so again, if they do respond well, which a lot of people do in general, we would leave them and say follow up, of course, but or come back if you have any residual issues. So that is how we would look at it. And also, there are key red flags for endometriosis. Again, fertility is one, right? And I think the mechanical approach, endo's effect on fertility, I do think, the mechanical approach has a lot of benefits, treating it with an excision surgery, it can be very beneficial for fertility. But there's some red flags with endo that we would know, have a higher suspicion. Family history, very, very important. Any history of any autoimmune, it's very common, right? Ehlers-Danlos, POTS, Hashimoto's, thyroiditis, vitiligo, things like that. You're building a picture of,
Right.
do I feel this is endo? Is it around, do your symptoms correlate with starting or stopping some birth control maybe? You were doing well and then you came off it. The classic endo patient would say, I was doing very well on birth control, but then, I got married, looking to start a family, came off of it, and now I'm having all these symptoms. So it's like being a detective and listening, a lot of listening, and trying to build your picture and thinking, what is the likelihood?
Okay. So then, the procedure that you're doing after excision, or to deal with the pain and the inflammatory process, can you talk about what that looks like and what the experience is for the patient?
Yes. So essentially, I had had my own issues, and mine were correlating with a postpartum of pelvic pain and bladder, bowel, intercourse issues. And I didn't really like what was offered to me other than the pelvic floor PT. I wanted, so then I created something that is based on what I would have wanted as a patient.
Okay.
So that's where this comes from. So what it is it's a simple office-based procedure, external, which is kind of nothing's going internal. So external on the medial buttock,
Okay.
right? So nothing's going in anyone's inside vagina or anything. But conceptually, it's a treatment where patients would have it 9 in the morning and they'd be at their 10 or 10:30 work meeting. So there's no downtime, there's no anesthesia. So that's what's different about it because the needle is just so small, right? You don't need a band-aid or it's a small, longer needle, but very thin and flimsy to get to tunnel it under ultrasound to where we need to go to treat the nerves and the muscles of the pelvis conceptually. So it's a high volume technique to open up so that the nerves can flow freely and not be in a traffic jam and also get more blood flow to them.
And then is this a one-time procedure?
It's three on each side, three on the right because it's a bilateral nature of the pelvis. So you do three on the right and three on the left. So if people are coming in from far away and they just have time for one, we wouldn't even offer it because you can't desensitize a peripheral nerve in one treatment. It's not like it doesn't turn off right away. It's every time it calms down a little bit more to then a more normal state.
Interesting. And then once this is done, then are you finding that most or all these patients are now pain-free?
Yeah, I mean, we're collecting data and publishing quite often on it. So essentially, 75% of patients are having a statistically significant improvement in pain and function. And I mean, we're really reducing opioids. I mean, there's a 68% reduction in opioids use
Wow.
once dosed. There's a 93% reduction in going to the emergency room for your pelvic pain anymore. Essentially, once you meet us, patients really stop going to the ER for their pelvic pain. Our data is showing that we're keeping patients working and present at work. So there's a significant reduction in absenteeism, right? Patients are able to go to work, and presenteeism is much better. So presenteeism validated questionnaires are about being at work and how many hours a week are you affected by your pelvic pain. So we're really helping our patients have a career, go to work, and stay present at work, and really showing an improvement in function. Right, we're particularly good at intercourse, helping patients have intercourse, bowel, bladder, sleep. Exercise. So the functional improvements range anywhere from a 35 to 55% improvement in your function after. So yes, this is the data we're
Wow.
collecting on thousands of patients now nationwide, and we're publishing on it quite often. We have 9 publications at this point and 4 pending on the PRM protocol. And yes, I mean our most recent was the comprehensive approach to endometriosis, right? Working PRM and excision surgeries, the PRM protocol and an excision surgery. So yes, and we're publishing on vulvodynia, vaginismus, really a spectrum.
Wow, this is incredible, incredible news. Now, how would this fit in with pelvic floor PT? Because pelvic rehabilitation is different. Do you find that patients also need that, or is it a case by case basis?
Yes, we encourage patients to go to pelvic floor PT simultaneously while they're getting the PRM protocol. It is different. We are not physical therapists. We are MDs, DOs, and some nurse practitioners. We're doing a direct treatment right to the nerves and muscles under ultrasound. So it is different, but to optimize the treatment, pelvic as an adjunct, pelvic floor PT is a great way to do that. That's how I would describe it. It's a
Okay.
great way to optimize the PRM protocol. Certain patients have had a significant amount of physical therapy prior to coming to us, and so they may opt to do more of their home exercise program with their breathing, or maybe something like your pace yoga from Dusty and Miller to really optimize the PRM protocol that way. So virtual is also an option.
Okay. Wow. Unbelievably fascinating. So the way it would work is I'm a woman, I have endo, I'm still having pelvic pain. Well, and again, the way you describe pelvic pain, where it's not just the typical one we see when it comes to having our menstrual cycle, but it can occur in different parts of the body. This is where your protocol would be really, really helpful that patient.
That is correct. Yes, we've published on treating bladder pain syndrome IC with our protocol. So some patients, it really is just bladder.
Okay.
So really, we can anything along the pelvic floor sling we could help with,
Okay.
right? Because we're treating the nerves and the muscles that innervate the entire pelvic floor sling.
Wow.
So bladder, bowel, intercourse. Really, we say any pain or discomfort from the belly button to the mid thigh.
Okay.
Because sometimes, again, patients they know their own body, so they describe it more as a discomfort, with bladder filling or intercourse rather than a significant pain.
Okay. Wow. So is there anything else that you would like to share that would help those who are listening? Because so many women struggle. And like I said, my audience just loves this topic, but you're the expert here. So there may be something I didn't bring up, or maybe even just a summary that you would like to share before we close out.
Yeah, I think two things is really it is important to take a comprehensive look at endometriosis. So, in addition, at Pelvic Rehabilitation Medicine, we have an integrative nutrition course specifically for endometriosis, also as a healthy gut course. And then we also have behavioral health courses as well. Retraining your pelvic pain. Let's talk about sex. Things that are important in down regulating your central nervous system. So it is important to take a comprehensive approach, similar to the book Beating Endo. I think it's a fabulous book, and it really is. If you look at endometriosis that way, I think there are a lot of lifestyle modifications that can help with it.
Okay.
And then number two, yeah, I with the PRM protocol, I think there's been some myths that it's a bunch of trigger point injections or that it's for pain. Of course, it's for pain, improving pain and function, right? As a rehab doc, return to function is our mantra. But really, a lot of it is really trying to decrease the inflammatory process that is in the pelvis with endometriosis. Reversing that neurogenic inflammation can be very helpful, really in treating pain, improving function, of course, but also endometriosis proliferates in an inflammatory environment. So if there's a lot of those pro-inflammatory cytokines or that inflammatory soup swimming around in the pelvis, it's like a petri dish for endometriosis to grow. So conceptually, that is, we do encourage patients to check in annually with endometriosis, really just to try to keep that inflammatory process at bay in the pelvis as much as possible.
Awesome. Wow. Well, I'm really happy that we connected on this. Like, there's just so many angles to talk about endometriosis. And this is definitely a new one for me. And I really appreciate your data-driven approach and the holistic approach, because you're right, it's complex. And, it's very difficult as a patient to hunt all the different types of clinicians that you need to work with and coordinating that yourself. So I love that you guys are keeping it in one place. I think that's just a smart move, business wise and for the patient care. So kudos to you.
Thank you, Georgie. Thank you so much for having me and for what you do. I really enjoy your podcast, and it's wonderful for women's health.
Thank you so much. Thank you for joining me today on Fempower Health. If you'd like to continue the conversation, please follow me on social media. I am most active on Instagram, LinkedIn, as well as TikTok. You can also subscribe to the weekly newsletter if you want to stay off social media to get the latest and greatest updates. And you can find a link to that either on my website, fempower-health.com, which is a hub to all the different health topics I've covered over the past 5 years, or you can go to the show notes where there's links to all the helpful resources that are relevant to this discussion. And if you know of someone in your life who would benefit from this information, please do pass this along, because that is how we can ensure this important information reaches those who need it most. And for anything that is discussed medically, please understand that none of what we share on Fempower Health is medical advice. It is all for information purposes only, and only a conversation between you and your doctor can give you the care that you need. Thank you very much.